Good afternoon, everyone. My name is Ruby Sound, and I'm the co-chair of the Special Interest Group of Public Awareness of the PCOS Society of India. On behalf of the entire PCOS Society, I welcome all the participants in today's program. Since I'm representing the PCOS Society of India, I'm here to continue the season 1 of a public awareness program called Vijeta. Vijeta is a program which is meant for public awareness in the interest of informing everybody and giving appropriate knowledge about what is PCOS. As we know, PCOS is an acronym of polycystic ovarian syndrome, and there are a lot of factors associated with it. So, the season 1, which is going to be in 6 episodes, it's all about the PCOS and its effect on fertility. So, in the first episode, we discussed about what is PCOS and how it affects fertility and the basics of it. And we are an eminent speaker in the previous session. So we continue today, and today is episode 2, where we are going to talk about the diagnosis and investigations, because we know that it is very, very important for the proper diagnosis of PCOS. Investigations are important when a couple is fighting with infertility, because at least 70 to 80% of PCOS women struggle with this infertility. All our doubts will be cleared by our eminent speaker today, who is Dr. Shobna Patade. Before I introduce her and before we move ahead, let's just quickly go through a small quiz which will help you understand how much do you know about this topic. And throughout the session, we will be able to help you reveal all these questions. So to begin the session, I request my technical team to present a few quiz questions. And all the participants are requested to answer these questions in the given allocated time. So begin the quiz session. I will request my technical team to put the first question on the screen. So everybody is requested to answer either as yes or no. The first question is, infertility means inability to conceive after 1 year of regular unprotected intercourse. I emphasize the word 1 year of regular unprotected intercourse. Does this mean infertility if you are not able to conceive? Please answer as yes and no. Majority of the participants have said yes, it means it is infertility if you are not able to conceive. I will come back to the correct answer at the end of the session, where I will be asking the same questions once again. Now, question number 2 is, HSG means hysterosalpinography. It is a name of a test which is done to check the patency of fallopian tubes. I repeat the question. HSG, which means hysterosalpinography. This is the name of a diagnostic test which is done to check if your fallopian tubes are working properly or not, if they open or not. So is this answer correct or not correct? So please answer as yes or no. So we have 80% of the audience who said yes, it is a test, and people are still answering. So 86% of people have said yes, it is a test which is used to check the patency. Okay, the next question will be displayed on the screen now, which is, primary infertility means people who have conceived in the past but having difficulty currently. Primary infertility means people who have conceived in the past, but this time they are finding it very difficult to conceive. Is this answer correct or no? So please answer as yes or no. So there's a mixed review about this, and our speaker will throw some light on this to give you the correct explanation on this. We still have 5 more seconds, 2 seconds left. So 67% said no, it is not, and only 33% said that yes, primary infertility means who have conceived in the past. Over to the next question now. Question number 4. Serum AMH, which is a blood test of anti-Mullerian hormone, will be very low in PCOS patients. So is this correct or no? Serum AH is a blood test which is performed. So will it be very low in PCOS? So we will throw upon light on different diagnostic tests which are done in PCOS patients in today's session. 5 seconds left. So 86% said no, it is not very low in PCOS, but 14% are saying that yes, it is very low in the PCOS patients. Question number 5, please. PCOS women have a high risk of pregnancy complications like miscarriages, diabetes, high blood pressure, etc. So please answer as yes or no. Question is, PCOS women have a higher risk of pregnancy complications. Last 10 seconds remaining. So among all the participants, 3/4 of you all have said the 75% that yes, PCOS women have higher risk of complications, whereas 25% say no, there is no risk associated with pregnancy complications. Over to the next question, please. Azoospermia males means those men who have a nil sperm count can be benefited by assisted reproduction techniques, which is available and which is the very latest technique now. I repeat the question, azoospermia, which means those men who have a nil sperm count, can they be benefited by assisted reproduction techniques? We're talking about also males and not only female partners. Last 2 seconds remaining. Where 100% of people are saying that yes, they can be helped by assisted reproduction techniques which are available nowadays. Over to the next question now. Question number 7 is, recurrent termination of pregnancy can be a risk factor of infertility. This means those who have undergone DNC because of the termination of pregnancies, is it a risk factor for infertility? Please answer as either yes or no. Last 5 seconds remaining for you to answer the question. So only 14% of people say that no, it is not a risk factor for infertility, but majority of people have said 86% that yes, it is a risk factor of infertility. May I have the last question, please now? Question number 8 is, ovulation tracking is done using ultrasonography. Ovulation tracking is done using ultrasonography. Is it yes or no according to you? Ultrasonography is also called as USG as a short form. So is ovulation tracking done using USG is the question. So as we end the question, we have 75% of people saying that yes, it can be done using ultrasonography, and 25% saying no, it does not used for ovulation tracking. So this brings us to the end of the small quiz, and so this will help us understand these points and answer all these questions in a good presentation coming up now. Now for this, I would like to invite the chair of the special interest group of the PCOS Society of India, and ma'am is the lead of this program called Vijeta. It's my privilege to introduce ma'am, who is also the committee member of the PCOS Society. Ma'am is a practicing gynecologist. She's the director of Fatare Fertility and Research Center based in Belgaum. Ma'am is a visiting professor and a PhD guide of OBGY KLE's University in Belgaum. She's been the president of the Karnataka chapter of ESA 2019 to 2021 and a former president of the Karnataka Society of Obstetricians Association 2019 and 2020. Ma'am is also an honorary secretary of the Fertility Preservation Society of India. Ma'am extensively works in these areas and she has a special interest in not only PCOS but the fertility preservation, recurrent pregnancy losses, and genital tuberculosis. I think no one better than Ma'am can explain us what are the diagnostic tests and what investigations to be done in a couple who's struggling with infertility, especially in a couple where the female is suffering from PCOS. Ma'am, I welcome you with both my hands folded and I request you to kindly throw some light on this topic and I request you to give your presentation now. Thank you so much, ma'am.
Thank you very much, Ruby, for that very kind introduction. Thank you so very much. Hello everyone. So I'm very happy to be talking to you all today on this very important topic, PCOS and fertility. The very fact that so many of you have joined for this program means, like, either you must be diagnosed as having a PCOS or there may be a family member who is having PCOS or a friend. And that's the reason you people are here. And the way you people have answered the poll also indicates that you have, a good knowledge about what this fertility and PCOS means. Now, the question which we need to ask ourselves is, see, today we are in a world where at the click of the button, we are going to get a lot of information, right? Then why should we do this program? Why should we do this webinar? And let me tell you, a lot of effort goes when we bring a webinar like this. There are a lot of back-end people who are all working here and to bring a program like this. Why should we do that? I'm sure you know the answer, but I just want to share with you. I happened to go through all the videos, before this presentation. I wanted to see what are the information that is being given in the internet and the YouTube and all that. And to my surprise, I found that many of the people who are talking about it, they are not even scientific people. They're not scientific. I mean, they do not know. And we have been in this field almost 25 years. So we know what are the vagaries, we know what are the variations. So it makes a huge difference when a society like PCOS Society of India comes forward and says, this is the thing that we need to do. Okay, so getting information is important, but getting information from the right kind of a people in the right time and the right way, the right dosage, what we are talking about, it is so very important. I'm so happy that you people have joined. I'm sure you're going to be benefited. And so we move forward I'll move forward with my presentation, right? Okay, so today we are going to talk about PCOS and fertility. And this is the episode 2 of session 1. So as Ruby already said, what is PCOS? So PCOS is an acronym for Polycystic Ovarian Syndrome, PCOS. Now there are many other names it has been called by, like this also called as PCO, PCOM, PCOD. So the patients get confused. Is it the same thing what we are talking about or is it different? But it is same. Like if you say either PCOS or PCO, PCOD, they're all same. So generally the right terminology will be Polycystic Ovarian Syndrome. And 1 in every 5 Indian women suffers from PCOS. You can see how big the problem is. If we say every 5 women we see, 1 of them is suffering from PCOS, and that means it's a huge problem. And PCOS can occur at any age, starting with the first occurrence of menstruation. And the majority of women are diagnosed as having PCOS somewhere between the age of 20 to 30 years. So then now, like how does it PCOS affect a woman? So actually PCOS is called as a metabolic malady. It's a mother of all lifestyle disorder. That is what it is called. So that means what? It can affect the woman right from adolescent through the reproductive years and to menopause. This is what is important for us to understand. So in the younger girls, we can see that it can cause menstrual irregularities, It can be a cosmetic issue because they can have, a lot of acne and hair growth on the face, and they can have this, dark pigmentation in the skin, and it does affect mental health. This is one thing probably not many women are aware of. PCOS can affect the mental health. So the patient can be irritable, she can have a lot of mood swings, and depression. These are all the problems which can be present by when the woman has got a PCOS. The next in the reproductive age group, what we are seeing is infertility, which is what we are going to talk today. And in case they conceive also, this woman will have miscarriages and pregnancy complications like diabetes, that is high blood sugar. Pre-eclampsia is nothing but high blood pressure. So these women can have high blood sugar and high blood pressure. And as the age advances, as we all know that, the chance of getting a hypertension and diabetes and heart disease becomes more. This is more common in a woman with PCOS. And this is what we call it as a metabolic syndrome. That's called as a metabolic syndrome. There is excessive weight and there's high cholesterol, heart problem, high blood pressure, high sugar. So these are all the problems what we see as the woman age advances. And if this is not treated and, if not picked up earlier, this woman can end up having cancer of the uterus as well. And obesity can be a problem, right? And in any age group, obesity is one of they go hand in hand. Most of the women with PCOS will have obesity and they go hand in hand. So today we'll be talking about infertility. Now let's talk about what is infertility. So I think they all answered correctly. I think majority of you all answered correctly of this question of what is infertility. If a woman, after 1 year of regular unprotected intercourse, if she does not conceive, if she does not become pregnant, that means the husband and wife are having a regular intercourse and they're staying together, they're having regular intercourse and they do not conceive even by the end of 1 year, then we call it as an infertility. But having said that, it is important for us to understand, but if the woman is more than 35 years of age group, we take it as 6 months. I'll give you a reason why after 35 years we are taking it as a 6 months. Next question is, what is primary infertility? Primary means she has never conceived in the past. First time, like she has never conceived. She's infertile. Secondary infertility, that means she has conceived. Secondary means first time she has had either a baby or she has had a miscarriage, or even if a tubal pregnancy she had, that means it is taken as she has conceived in the past. Now, currently, she is not getting pregnant. Now, in this context, we see two group of people. Okay, there's one group of people who are just married maybe 3 months or 4 months, and they come to us and tell, doctor, I'm married for 3 months and we are having regular sex, but she is not conceived. Okay, this is one group of people we see in our practice. Now, what is important for us to understand is human beings are not very fertile species. Unlike the rat and rabbits and all that, we are not very fertile species, right? Even if a husband is normal, if the wife is normal, everything is normal with them, and every day they have a sex, the chance of pregnancy per cycle is only 30%. This is what everybody needs to understand. So that is why we say 1 year. Okay, so it can only happen in the movie. Have you seen movies? You see, right? The guy touches the woman, and the next scene, what you see is she's standing in front of the sink, and then she's vomiting. Yeah, that doesn't happen like that. It doesn't happen in the reality. It is not like that. So the patient, we say that's why 1 year, if they have unprotected intercourse, if they do not conceive, then we call it as an infertility. There's another group of patients, like, she's already 35 and she's married for 6 years or 8 years. And when we ask them why you did not come for a treatment, then she'll say, no, we wanted to try naturally. My mother conceived late, my aunt conceived late. So we wanted to try naturally. So we didn't come. So both are extremes. So that's why it is important for us to know if they are trying on having a regular intercourse, staying together for 1 year, if they don't conceive, then it must be taken as it is infertility. Now, one of the most important thing, this is very important for us to know when fertility we are talking about, age is a very, very important factor, right? 20 to 30 years is the best age for a woman to get pregnant. Then somebody will be laughing at me, when I say this, they'll say, madam, what, 30 years? We are still studying and, we are starting our profession, right? So 20 to 30 years, that's the best age. After 30 years, the fertility rates starts dropping down. After 35 years, sharp dip. When they come at 40, we say, what, you have come so late, how can I help you? Right? Now we are seeing one kind of a trend, we are seeing that, girls are attaining menarche. When I say menarche, that means it's the first menses. Earlier, the girls used to get their first menses when they were 9th standard or 10th standard. Now we are seeing girls, they get their menses when they're 4th standard, 5th standard, right? And then what happens is they're getting their periods earlier, and we are getting, all women are getting menopause also, they're reaching menopause also earlier. A woman in India attain menopause 6 years earlier as compared to the Western counterpart. So what is happening? They are getting their periods earlier, they are getting menopause earlier, they are getting married later, and they are delaying their childbirth. This is the social evolution what we are seeing. And this is hitting every girl. And most of the time the girls think because she's getting regular periods, nothing, I am getting my periods regularly, I think everything must be normal inside. The so-called unexplained infertility. Why I am not conceiving? It may be just that it's the aging of your ovary. And to look at, when we see the girls like that, they look so beautiful. We can't even say that they're married. They look like that. But the age first goes and hits the ovary. It doesn't hit any other organ. It won't hit the ovary. So the ovary starts aging. And this is how, pregnancy rates gets affected. And this is not only the quantity, but the quality of the egg also declines as the age advances. There are also other risk factors for infertility, like as I said, late childbearing, smoking, previous history of abortions. If the woman has undergone an MTP or he has undergone a DNC, when they undergo this procedure called DNC, so because to terminate the pregnancy or for whatever reason it is, if she has excessive bleeding, if she has undergone, that becomes one of the risk factor for infertility. And unfortunately, some women may have some kind of a cancer, a breast cancer, and if they have taken a radiation or a drugs for the cancer, those women are at a high risk of developing infertility. Another important thing which we need to understand is unsafe sex, multiple partners. This is one of the important risk factor to develop sexually transmitted infections. So what happens to this woman? These women will have white discharge, lower abdominal pain, recurrent urinary infection. Okay, so it may be with both the partners, or it may be with one partner, and this is we suspect a sexually transmitted infection in such women, and these are the women they can end up having infertility. So one more thing which I wanted to add here is, when we are talking about the late childbearing, this factor what we are telling. So we know that there is in society evolution has happened. Most of the girls are not getting married by the age of 30. So what can be done? This question, I'm sure the moment I tell this question will come in the mind of some people who have not yet got married and who understand this. So what can be done is, we do something called in assisted reproductive technique, we have something called as social freezing. We can freeze the oocyte. We can freeze the oocyte, that can be kept, and then once she gets married, then it can be taken and then it can be used for her to get pregnant. This is called as social freezing. This facility is available in India, and most of the well-set IVF clinic are able to do this social freezing or egg oocyte freezing, what we call. Now coming to the causes of infertility. What are the causes? Right? So it is not only the female, it's a male or male factor also can be there, as we all know that. So male is responsible in 30% of the cases. Female, it is responsible in 30% of the cases. In another 30%, there could be both male and female factor. In 10% of the cases, we call it as unexplained infertility. Unexplained means it appears like, male, everything you have done for the male, it is normal. Everything we have done in the female, it is normal, but still they are not conceiving. This is called as an unexplained infertility. Now, when we talk about female infertility, what are the things which we need to test? Obviously, we all know that, if you want to test for ovulation, if you want to test for fertility, her uterus must be normal, her fallopian tube must be normal and open, and she must be producing eggs, right? And they must be having a regular sexual intercourse, right? And also sometimes, even if everything is normal, sometimes if they have undergone a previous cesarean section, after that they stop conceiving, or if they have undergone an appendicectomy, there may be adhesions. Adhesions means they are adherent, they are stuck to one another. If the organs are stuck to one another inside, we call it as a peritoneal factor. That time also the patient can have difficulty in getting pregnant. So here we are telling that ovulation factor is responsible in 40% of the cases. Tube can be affected in 40%, in unexplained 10 to 15%, and uterus is responsible in 5% of the cases. So when we talk about ovulation disorder, means eggs are not being produced properly. In that, 85% is because of polycystic ovarian syndrome. So that's why we keep on harping about polycystic ovarian syndrome. That's why we keep talking about it again and again. Okay, now the patient has come to us. Let's say that patient has come to us with to a gynecologist or an fertility specialist to tell that she's infertile. So what are the things we do generally? So in general examination, it is very important that we do both a general examination and pelvic examination. So in general examination, we look at the BMI, we look at the height, weight, and calculate the BMI. It is important, very important. If your doctor has not done it, please ask her to do, because in PCOS, we are talking about obesity, and it is very important they look at the BMI, right? And we look at the thyroid gland. This is a gland which is present in front of the neck here. If that gets affected, yes, the cycles can become irregular, and it can affect pregnancy. We also look at the discharge from the breast and signs of excess of male hormones. And this, I think, last webinar, Dr. Duru madam has very beautifully told you, how they can have acne on the face, and they can have excessive hair growth, in the chin, in the mush, and in sideburns. So those things can be there. And also look for sign of insulin resistance. Insulin resistance is that black velvety thing what we see in the neck, acanthosis nigricans, what we call. That is what we need to look for in these patients, right? So next comes our pelvic examination. Somehow, I don't know, our women are very scared or skeptical about getting a pelvic examination. They have reason. They'll say, madam, I'm bleeding. Today is not the right day. Tomorrow I will come. I don't know why they're scared. But we need to understand that without a pelvic examination, none of your ultrasonography or MRI is going to work. Because it is important that we do a pelvic examination. There could be so many problems which we may not be able to pick up by advanced investigation what we do, right? So cervical, simple thing like there may be a cervical vaginal discharge, or there could be a polyp in the cervix, right? And we also look at whether the uterine size is normal, uterus is normal or not, any tumor there. What about the ovaries? Is it normal size or is it enlarged? Or is there a pain? When some women will have severe pain when we do an examination. Is it a case of endometriosis? There's one condition which is called as an endometriosis, which can be diagnosed by doing a pelvic examination. Asking a woman to give a fertility treatment without doing a pelvic examination is like telling, you go to an ophthalmologist and tell them, don't look at my eyes, or going to the dentist and telling, don't look at my teeth, but you give me treatment. It's like that. Okay, so it's just more of a scare rather than it's of anything else. Okay, I request if you have anything concern, you please talk to a gynecologist, have a thorough examination, and then we proceed with our investigations. So coming to the blood test. Now these are all the blood tests done. So remember that when I write so many blood tests, that doesn't mean we are going to draw about 200 ml of blood from you. It's not like that. The more number of tests is more number of blood, and my God, what investigations we are doing. It's not like that. 10 to 15 ml of blood, we should be able to do all these blood tests. What are the tests we are doing? We are looking at FSH, LH, and E2. This will give us how the hormones in the bodies are working. These are all hormones are nothing but they are messengers which are carrying the information from the higher center, from your hypothalamus and brain. It sends it to the ovary, and then ovary will start acting. They all work like an orchestra, you see. In an orchestra, there are so many people who are working, right? They all have to work in a very synchronous way. Suppose one of the player also makes a mistake there, everything it will become asynchronous. So similarly, the hypothalamus, which is in the brain, pituitary, your ovary, uterus, everything has to work in a very synchronous way, and they are working 24/7, 365 days to make you get that menses or to get pregnant. So anything here, it can affect us. So that's why it is important that we do all these tests to find out whether they are working well or not. All patients, fertility problem is there. We look at the thyroid testing we do a prolactin. Prolactin is also called as a stress hormone, and that can be, if it's raised also, patient can have irregular cycles. Another important test, we asked this question as well, serum AMH. AMH stands for anti-Mullerian hormone in PCOS patients. So it gives us the ovarian reserve. How much is the reserve in this lady? I said as the age advances, the egg number becomes less. Correct? So if the egg number becomes less, your AMH level also will start falling down. In PCOS, there is always a high AMH. So one of the diagnoses of, when we make a diagnosis of PCOS disease, we find out that the AMH level is high. Generally, it is more than 3.5 nanogram per ml. We make a diagnosis and say, okay, it appears like a PCOS. And if there is a low ovarian reserve, it will be less than 1.2 nanogram per ml. Right? So AMH in PCOS and all PCOS, AMH is high. It is not low. And coming to the sugar testing, we have told you already in the last webinar as well. Every woman who have come with infertility also and PCOS also, we check for a oral glucose tolerance test. All infertility also we check. Why? Because our country is called as a diabetes capital, right? So that diabetes is very rampant in our women. So we do the glucose tolerance test and find out whether she is diabetic or pre-diabetic. We also do vitamin D3 and vitamin B12. Vitamin D3 is quite common. It has been told that, like, because we stay indoor, we are not going outside and working, and we're sitting in an AC room, your vitamin D3 level is bound to be less, and it will produce multiple symptoms, and one of them can be irregular cycles. And vitamin B12, especially we have seen in a vegetarian, if they have a vegetarian diet, we see that vitamin B12 deficiency is more common. So that also, as a good practice, we check both vitamin D3 and vitamin B12. Serum insulin, we are talking about hyperinsulinemia, insulin level is high. Can we test serum insulin? It's a common sense question, like, should we test? But unfortunately, there is no standardized clinical test available right now to check the serum insulin level. Okay, so now we'll start with, we have done an examination, we have done the blood test, and then we have to move around and say, okay, now we are going to assess the uterus, ovaries, and we also have to test for ovulation, look for the fallopian tubes, and also I told you about the peritoneal adhesions. So what do we do? So we do something called as a baseline scan. Baseline scan. See, the word itself is self-explanatory. That means we are doing before 5 days of the cycle. We generally do a transvaginal sonography. There are two types of scan. When we put our probe on the tummy and we do, that is called as transabdominal sonography. We are doing on the tummy. This is transvaginal. So transvaginal scan is what we do in fertility evaluation. We do a transvaginal sonography. We look at the uterus. If the uterus is normal and whether any fibroid is there or any polyp is there, any problem in the uterus, basically we are looking at that. And we also look at the normalcy of the ovary, and we look at the antral follicle count. This is called as an AFC. That's an AFC is an acronym for antral follicle count. Please remember that we cannot see fallopian tube unless they are enlarged. In an ultrasonography, we cannot see. In a normal ultrasonography, when we do, we cannot see the fallopian tube unless they are distended, or if there is a hydrosalpinx, we will not be able to see. So basically, we are looking at the uterus, we are looking at the ovary, and also we are looking at the antral follicle count. Look at this. So this is the ovary. When we see like this, we are very happy. Can you see all the small black things? These are all the follicles. We call it as a good ovarian reserve. Okay. When a woman comes to us with like this, when you do a scan, you see 1 or 2. Generally, we say if it's less than 5, then we call it as a poor ovarian reserve. That means her reserve is less. Just remember, your bank balance is very less. When you find like that, when you say bank balance is less, it's an alert sign, right? Similarly, when you find that, the number of follicles are less, you have to be alert. Your AMH is low, your antral follicle count is low, then you have to be worried. But in PCOS, what happens? So in PCOS, we find 20 or more follicles. The number of follicles, what we see in PCOS is quite high, quite more. Okay, it could be present in one ovary, or it could be present in both the ovaries. Or the volume also, when we measure it, it's a huge, big ovaries, what we see in polycystic ovarian syndrome. And also we add a new technology which is called as a 3D ultrasonography. It's a high-tech technology which is available, yes, and lot of abnormality which in the uterus, and we can make out, and also we can throw some colors into the organs and find out how is the blood supply of these organs. So this is called as 3D ultrasonography. Now coming to the ovulatory factor. So coming to the ovulatory factor. So ovulation, whether this woman is having ovulation or not. That's a question which we need to answer. Any woman, for all practical purposes, if she is getting a regular period, we take it as that she is ovulating. Ovulating means that she is releasing the egg properly. That's what it means, right? But if the woman has got irregular cycles, suppose she has got irregular cycles, that means she has got amenorrhea. We call it as amenorrhea. Menorrhea means bleeding. A means no bleeding. That is called as amenorrhea. Or oligomenorrhea. Menorrhea is bleeding, oligo means irregular, infrequent bleeding. So normally it is taken as the woman should get a periods between 21 days to 35 days. Anything less than 21 days is abnormal. Anything more than 35 days is abnormal. So many a times we have women who come like, I was getting my periods on 26 days. Now I'm getting 28 days. What is the problem? I'm worried. I'm concerned. Do you think we should worry about such a woman? Don't have to worry. Okay. It's not like it's a mission body. It's a body actually. It is not a robot, right? It's not like, 2 plus 2 is 4 only and you have to get on 28 after 28 days on this particular time, you will get your periods. It's not like that. So that's why we are giving a range like, anywhere between 21 days to 35 days, if the woman can get a periods and that is taken as normal. So then the question comes, why, like, in PCOS, you are telling that, there are so many follicles present, then why should PCOS leads to infertility? Right? So you are telling me that, when you do an ultrasonography, you find so many follicles and so many eggs are there, more than 20, you are telling why PCOS should lead to infertility. Now remember that, there is a follicles there, but this woman generally will have irregular periods. That means she's not producing eggs. The eggs are all there. They're all small. They don't grow in a size properly. They don't get ovulated. So though there are eggs there is an ovulation. Eggs are not being released. And also there is a poor egg quality. Secondly, there could be increased male hormones. We told you in PCOS patients, both man and woman will have both male hormones and female hormones. Correct? In a woman also there will be male hormones normally. But if it becomes an excess, then it can lead to decreased fertilization and poor embryo formation. And there is decreased implantation as well. And it doesn't get pregnancy, does not happen. And hence there is a decreased pregnancy in these cases. How do you find out whether the woman is producing the egg or not? This is again the one poll question was there. How do you find out? We cannot examine the woman clinically and find out whether she is ovulating or not. Right? We cannot do blood test and find out whether the woman is ovulating or not. Though they are tests, but generally it is follicular monitoring is by ultrasonography. We do a transvaginal sonography serially in a woman, maybe 3 to 4 times, okay, in a month, and just to find out whether she is getting an egg like that and whether it's growing, whether it has ruptured or not. All these things we can make out only by follicular monitoring, and we call it as short form like FM. Patient is for FM. That means is for follicular monitoring. Okay. So what are the tests that are available? Now we found out about the ovulation, whether it is happening or not. What is the test which we are going to do? How will you find out whether the tubes are patent or not? So there are several tests that are available. One is hysterosalpingography, another one is psychosis, sonohysterosalpingography, and laparoscopy with CPT, chromopertubation. I think we medical profession, I think we use a lot of short forms, and probably that will create a confusion in the patient's layperson's mind. I'm trying to make it as simplified as possible. Please write down if you have not understood whatever has spoken. Please put it in the question box. We will explain to you once again. Right? So of this, I'm going to talk to you only about 2 common things. One is hysterosalpingography. Now, hysterosalpingography is one of the very simple procedure. It can be done in any city across the country. Right? This is you take an X-ray of the uterus and the fallopian tube. Right? You push a dye through the cervix, and this is how the uterus, it looks like a triangle shape like this. Correct? And then can you see this? This is a line. That's a fallopian tube. This is a fallopian tube. Once we push a dye from here, the dye goes from here, it goes through that and it will spill out. It has come out. That means we are telling that the tubes are open. Patent tubes means the tubes are open. This is a normal hysterosalpingography, HSG, hysterosalpingography. Now, in this case, you can see here that look at this tube here. This is a normal. Look at this. This tube is distended. This is an abnormal hydrosalpinx we call. This is an abnormal tube. These are abnormal fallopian tube, what we can see. So one is HSG, another is the laparoscopy. You must have heard about it, laparoscopy. What is laparoscopy? Laparoscopy is an operative procedure where we make small incision like this on the abdomen, right? And we put a scope. Scope is endoscope, which has got a light on its end, which is connected to a monitor. So once we put a scope like this, we can see like, we can see the uterus, we can see the fallopian tube, we can see the ovary. This is how it looks. If I stand on the right side of the patient, I'm putting a scope, this is how it is going to look, right? Uterus, this is the fallopian tube, and you can see the ovaries here. Can you see the ovaries there? Yeah. See here, this is a cyst. When the ovary, this is a normal ovary, this is an ovarian cyst. So actually we are looking into everything inside when we do an hysterolaparoscopy. So evaluation of uterine cavity. So how do you find out whether the uterus, where the baby is going to stay and remain in the uterus for 9 months, is it normal or not? How will we find out? We can find out by transvaginal sonography, which we did in baseline scan, which I explained to you already. We can also find out by hysterosalpingography, sonohysterogram, and hysteroscopy. These are all the different tests that are available. The doctor will decide for which patient, which kind of test has to be done. These are all the abnormalities which can be picked up. Don't get scared. I mean, we have picked up all the abnormalities. Not every woman will have all this problem. Please, don't think like, if I'm infertile, I may have fibroid, synechiae. No, it's not like that. These are all what we are talking about, 5%, 8%, 10%. Okay. So most of the patients with infertility, they will be able to conceive with medical treatment or with an IUI or with an ART, right? So when we talk about to a lay people, it's very important, because what is abnormal, that's all get stuck to your mind, and you'll remember, you'll start worrying about it. So this is how, if there's a polyp, this is how, like, there's a polyp will look inside the uterine cavity. Now I spoke about laparoscopy. This is hysteroscopy. In a laparoscopy, we saw the outside. From the outside, we went inside and saw like how the uterus and tubes and all see. In hysteroscopy, we use an endoscopic instrument, very small, thin instrument, and then we go through the cervix. It has a light at its end, and then, this is the light source is connected here, and you see everything here. This is connected to a monitor. In the monitor, you are going to see all these things. These are all the problems. This normal means it looks like this. If there is a polyp, it looks fibroid, it looks like this. If there is a septum, it looks like this. See, these are all the different abnormalities. What we can pick it up, and also not only pick it up, we can correct it then and there only. All these problems, whatever I'm showing you, all these problems can be corrected then and there only, in that sitting only. So male factor, whether isolated or combined with female infertility, is a contributing factor in about 50% of the cases. It's a huge number, right? So we cannot treat infertility without evaluating the male, because in 50% of the cases, either isolated or combined, this could be responsible. So how do we evaluate the male infertility? Again, history is very important. Physical examination is very important. And we do one test, everybody does. This is called a semen analysis, right? So it could be done manually, or now we also have a computer-assisted sperm testing, which is called as a CASA. Okay, this is a basic test which we do in all men, right? And an additional test, suppose there is a problem, there could be azoospermia, like that means there are no sperms at all, or there could be aspermia, that means semen only is not deposited. There could be umpteen number of problems in the male factor, but remember that, in ART, that is assisted reproductive technique, what we are talking about, IVF, ICSI and TC and all those things, they have really, the technology has advanced so much. Even in a man, if he says azoospermia, if it is non-obstructive, and we should be able to, obstructive or non-obstructive, we should be able to produce a pregnancy. So that is important for us to understand, that we will be able to help this couple. And if there is a problem, then when we do all these other tests, we do sperm DNA fragmentation test. If the sperm count is less, we do hormonal evaluation. We can also do an ultrasonography for a man and genetic testing. So these are all the tests depending upon the problem, what we have seen in this man, and we can do all this additional test. So the take-home message which I would like to give to you is, contact your gynecologist if you are unable to conceive naturally for a period of 1 year or more. If you are trying for pregnancy, if you do not conceive, please go and see a doctor. Be mindful of your symptoms. It is your body. Symptoms are happening to you. You should be able to tell, like, okay, now I think I'm putting on weight. I think a hair growth is more. Cycles are irregular. If you don't even know when your cycles you got, when was your last menstrual period, how mindful are we living? That's a question we need to ask ourselves. Many a times woman will come to us and say, when was your last period? She will look at her husband. Husband has to remember and tell, okay, no, you got your periods on that time. So this is no way to treat yourself, isn't it? So we should be mindful of our symptoms, and when we investigate, we need to investigate both male and the female partner, very important. And based on the report that it is PCOS or general non-PCOS also, based on that we give the treatment. And we know that for PCOS especially, we have new advanced treatment options are available. And the first line of treatment for PCOS women is lifestyle management. We have been harping on this time and again, which we are going to talk in the next episode of ours, which we are going to talk about lifestyle management. Definitely that episode you should not miss, because it matters to you the most actually. So I would conclude by telling you that, we have gone into the sedentary lifestyle, junk food domination, a sad evolution. We were monkey, we became a man, and with our lifestyle, we are becoming like that. I don't want to tell what it is, but you all know about it. So till we learn more further from the next webinar, till then, what I want to tell is eat less, eat on time, eat right, walk more, sleep well, and smile. Thank you so very much.
Thank you so much, ma'am, with those beautiful ending slides. Thank you so much. I welcome all the audience to be a part of our sessions by, being a part of our next episode. The next episode will be on the management of obese PCOS. We're going to talk about the diet and exercise. So I want everybody to join us for the next episode, which is going to be on the 23rd of March in the evening from 7 to 8 p.m. And I'll be as a speaker who will discuss on this important management to manage PCOS. So thank you so much, ma'am, once again, because what is most important is to first identify what are the symptoms. Like you said, be mindful of your symptoms, and diagnosis and investigations. Because many a times patients go without knowing that what test will be done. They just fear the test. Big names like HSG, like USG, what blood test will be done. So a lot of confusion is there, and with that fear, we don't know the test. People avoid the test, the cost of the test, who will do it. It will be in the same center, different center. So I think because you have given us such a good explanation, ma'am, that all the patients will know, okay, now if I have this symptom, these are the tests which I'm likely to be done. Or if, my daughter or my daughter-in-law is having these symptoms, I can help her to go through this investigation. So finally rule out whether she has PCOS or not, whether she's infertile or not. Sometimes just because the periods are not coming, they think I'm not going to get a baby. So unless you do the investigation test, you cannot finally conclude what is the problem and how to treat it. Once again, thank you so much, ma'am, for such a beautiful presentation. You made it so simple. It has helped all the attendees here to understand and become like some knowledge about the doctors, what they are saying before they say. So, ma'am, I think people have been very, very interactive. I have seen a few questions in the audience, and I request others also to please put their questions in the Q&A box so that, we can answer your questions. We have the expert in front of you today, and we still have some time. We are here till 4 o'clock to answer all your queries. Ma'am, I will request you to answer some of the queries which I can see in the chat box. Okay. So, ma'am, some of the questions you've already answered in your presentation. Okay. But some people have still asked, but I will come to such questions a little later. Now, one question which somebody has asked is, ma'am, how many cycles of follicular monitoring should be done before doing an advanced treatment? I think this patient wants to ask that, how many times we should continue doing before looking at IUI or IVF or ovulation induction. Can simple follicle monitoring be very helpful to conceive?
So I think how each one of us are different. No, fertility treatment for everyone will be different only. So it is so important for us to understand. A woman is only 22-year-old, right? Let's say the woman is 22-year-old. Husband is normal. They are married for 1 year or 2 years. Maximum we can go up to 6 cycles of follicular monitoring. That is a recommendation. 6 cycles we can give follicular monitoring. Let us say there's another woman who's 35-year-old, right? Married for 7 years, 8 years, right? So I will not tell her you go for 6 cycles of follicular monitoring and OI and time intercourse. So for every woman, the treatment plan has to be different. And your infertility specialist, whomever you go, they will definitely be able to guide you. But in general, follicular monitoring should not exceed 6 cycles.
Okay, I think that will take about 6 to 8 months. and then they can think of further advanced treatment. So very, very important, because in my experience, I've seen a lot of patients doing it for 1 year, 2 years, and trying to conceive naturally. I think that's spending a lot of time in not doing the right diagnosis. Okay, thank you so much, ma'am, for the answer. Now, this is a very particular question from a patient. She's mentioned that, Madam, I had an abortion in December 2022, and after this, I had a DNC. That means, cleaning and removal of that fetus. So, I had an abortion in December 2022. Will I have to undergo all the tests again, like I had done HSG and laparoscopy?
Not necessary, not necessary. Generally, what we do is, if all these are invasive procedures, HSG, laparoscopy, hysteroscopy, they are all invasive procedures. We will not repeat them. Generally, we will not repeat them. But if all blood tests, if they have been done 6 months prior, it's a good idea to repeat it. All these blood tests, whatever we are talking about, thyroid, prolactin, and AMH, and all those things, because it is dynamic, isn't it? As you age, it changes. So it's better we repeat that if it is done beyond 6 months.
Okay, it depends on other factors also. Correct. Okay. And there's from the audience, Ankita has asked this question. Doctor, serum test for infertility check are to be done on which day? Any specific day of the menstrual cycle?
Yeah. So most of the time when we call them on the baseline scan, see this FSH, LH, E2, this needs to be done before 5 days of the cycle only, right? But your thyroid, prolactin, AMH also, these are vitamin D3, B12, this all can be done any day when she comes back. So there's no particular thing, especially FSH, LH, and E2 when we do that, we would want to do on day 2 or day 3 of the cycle, that baseline when we are telling. Because there is a variation in the menstrual cycle. So it's important that we do initially. Rest all the things can be done anytime. AMH also can be done any day of the cycle. No problem.
Okay, thank you. I hope you have got your answer, Ankita, for your question. And I think that has, solved query for a lot of other people. I can see one more question. My reports are normal, madam. My husband's reports are also normal. We are married for last 5 years, but not able to conceive. What could be the reason and what can we do now?
Yeah. So again, this is a very, very practical question. So practically we see this kind of a scenario in our on a day-to-day basis. So one group of patients are such that they will come and tell they would have done only follicular monitoring. One husband's report will be there many years back, and then they will keep on taking the tablet. One scan will be done, and then some blood test will be done. Forget about all the blood tests. Some blood tests here and there will be done. And then they will come and say, no, eggs have been released, my husband count is normal. What? They wouldn't have tested for tubal patency also. Years would have passed and they wouldn't have done for tubal patency test. This is a very unfortunate scenario. Okay. So this is one group of patients where we tell them, no, you're not even touch the eye of infertility. You're in that stage of your evaluation. You are not even test the tubal patency. How can we talk about giving treatment for you? Another group of patients is, yes, they would have undergone everything. They will have tubal laparoscopy, hysteroscopy, drilling would have been done. These are the different group of patients. So one of the things what we call is, if everything is normal, we call it as an unexplained, I told you, unexplained infertility. In such a scenario, if they have not gone for an IVF, definitely we recommend them they should go for an IVF, because you do not know in IUI the quality of the egg, because inside it is happening inside. You do not know. And that is where we take out, when we find out, we look at the oocyte, we find that, okay, oocytes are not good at all. That will happen only when we do an IVF. That's one thing. Another test which we do is immunological testing we do, and also we do a genetic testing. So these group of patients who find that everything is normal, still they are not conceiving. So these are the tests.
Okay. So I think this question you have explained all the tests. I think this patient who thinks all the tests, you must go back to the presentation, see the recording, and if you have missed certain tests, you should do it. Exactly. And if something is, you can discuss with your doctor, and those tests can be performed for both you and your husband to see if something is missing. Okay. Otherwise, genetic testing is also available. Luckily, we have that facility now, so you can check with your doctor. Okay, we have another question which is not related to diagnosis, ma'am, but if we can help Reena, the question is, are statins useful in PCOS and infertility? This is out of syllabus question for today, but I request you to.
No, I mean, statin, you should not be taken. I don't think PCOS patients, as a gynecologist, I prescribe statin. Yeah. And like starting a statin, there are definite indications for which it should be started, and this has to be done either by a physician or a cardiologist. So we as a gynecologist, if we find that there is a high cholesterol level or high triglyceride level, and we refer the patient to a cardiologist or a physician, and there is an indication, then they start. But as far as the PCOS is concerned, we do not start from our perspective, we do not start the patient on statin.
Correct. So, Reena, statin is usually given for anything related to heart conditions, not particularly to any PCOS, any gynecologist. Of course, we recommend metformin, which is diabetes-related medicine. But of course, like ma'am said, status is not prescribed by any gynecologist. So, I think you must check if somebody is prescribed, or you must go and take a second opinion for that.
The doctor who has prescribed, and probably they should be able to explain in what condition, what indication.
Some reason should be there, ma'am. There must be some reason for recommending. Yes, there must be some reason, but it is not for PCOS. That is very clear. Okay, thank you so much, ma'am, for your help. There is another question. A lot of questions are coming. Sorry if I've missed some questions, but let me take some important questions. Do I have to get admitted for HSG? I've been suggested, and will anesthesia be given?
Not at all. HSG is an outpatient procedure. Okay, and patient will come. It is done. Actually, we have in our own center a CR machine. So sometimes the gynecologists, if they don't have a CR machine, they will refer them to the radiology department. Where this HSG, because you need an X-ray machine to do this. Okay, and you don't have to admit the patient. We just give them sedation and atropine, and then we do the procedure. Earlier, the Ruby, I would like to tell here, they were using this Leach Wilkinson cannula. I do not know people who have undergone the HSG. They're using a cannula, metallic cannula to do this, push the dye. But nowadays we have very thin and nice, beautiful catheters which are available. They're very thin, and it is relatively painless. It can be done in 3 to 4 hours. They can go home. So this is one of the very simple tests can be done. In fact, when we are doing, the patient is looking at the monitor and she's seeing the tubes getting filled, and she'll say, okay, we are telling her, okay, see that your tubes are open, and she'll get up and go. The technology has helped us so much.
Okay. So I think if you have a fear of HCG, what was done in the past is different from what is done in today's time. And I think, ma'am, patient can go back to work also. It is it's a same day procedure.
Yes, maybe that day, we give her some sedation, so she'll be a little dizzy. Probably that day she can take rest, and then next day she can go.
Okay. Okay. One last question.
Laparoscopy, if you are done, we would recommend, because laparoscopy is done under anesthesia.
Yeah, this is the main difference for the patient. Yeah.
Laparoscopy, at least 2 or 3 days, preferably they should take rest.
Okay. One last question, ma'am. We are also running out of time. Because you mentioned about the test of doing blood sugars. Okay. And there is always a confusion. One person has asked why diabetes test is done for PCOS patient. So you've explained that.
We have been talking about insulin resistance, right? So insulin resistance, we have been talking. Whenever there's an insulin resistance, obviously that the diabetes, your sugars will go up. So and it is not enough if you just do one random blood sugar. So we are giving some kind of a glucose load has to be given and then done. That WHO has categorized it as you give a 75 grams glucose load and then you check the sugar. And then if it is IGT, there's a different value if it is less than 199. And if it is diabetic, then the sugar level is more than 2. That's what it is.
And I think, ma'am, it is very important for every girl because once she conceives, so she knows that if she's at any risk of developing diabetes, which is gestational diabetes during pregnancy, or she's going to remain non-diabetic. So I think all the tests which you have mentioned are very, very relevant for PCOS, especially when they're trying to conceive in infertile cases. I think, ma'am, you've answered most of the questions. Thank you very, very much from the bottom of my heart. You answered them so beautifully and simply. You really made it very simple. Thank you so much, ma'am. Now I think it's time for us to see and understand how much people have understood. I'm sure all of them are very attentive during your talk. Let's check that. So I will repeat all the questions, okay, and see how much they have been able to answer now. I request my team to share all the questions once again, and then we will also compare what you have answered earlier and what you have answered now and what is the correct answer. Okay, we begin with the first question immediately now. So the purpose of doing this and asking the same question is to reassure that whatever is being told by madam is being understood by everybody, and now you have more knowledge about the subject as what it was an hour before. So I'm waiting for the questions to be flashed on the screen. Okay. Now after 1 year of unprotected sex. So this was answered by 100% of people that yes, infertility means inability to answer. Can I have the question, please? The technical team may be able to display the question now. Please put the question once again. Question number 1. Okay, now everybody gets 40 seconds to answer this question again, and then I will tell you what is the correct answer. Is it yes or no? Now the answers are changing this time. You still have 10 seconds if you want to correct your answer or others to answer. Okay, now earlier 100% of people said yes, and now 11% have said no. Now the correct answer is that yes, it is a time duration of 1 year. Okay, in 1 year, if you're not able to conceive by doing a regular unprotected intercourse, this means it is a case of infertility. So the correct answer is yes, it is a period of 1 year. So those who have answered 18%, I think now it is clear to you. The infertility means that 1 year of not being able to conceive. Now we have the next question to be displayed on the screen, please. I know this is like a small exam, but it's very interesting. HSG test, which ma'am has already explained, is a test which is done to check the patency of the fallopian tubes. So the question is that to check whether the fallopian tubes are normal or not, HSG test, which is like a sonography or an X-ray, it is done for that purpose. I think ma'am has shown some diagrams. So whether it is yes or no. Ma'am also explained that, how HSG is in much advanced nowadays. So it's less of pain and more non-invasive types of a procedure. So we'll see what people answered before the session. And now 100% of people have said yes, it is to check the tubes. Now let's see what people mentioned before the session began. So only 14% of people were not too sure. They said no, it is not a test for fallopian tubes. But now, after the session, 100% of people agree that yes, it is a test to check the fallopian tubes. Thank you everybody for answering that question correctly. Thank you so much, ma'am. Ma'am, see, everybody was attentive in your class session. Thank you. Next question, please. The third question is, primary infertility means people who have conceived in the past but now are having difficulty in conceiving. So primary infertility means people who have conceived in the past but are having difficulty currently. So read the question properly. It says primary infertility. There are two types of infertilities, primary and secondary. So primary means what? Those who have conceived in the past but having a problem now. Think again to get the correct answer. The bars are changing. So now people have answered that only 29% agree that yes, it is primary infertility means have conceived in the past, and 71% said no. So let me compare with the question which I asked earlier and then tell you the correct answer. I will show you the screen where 67% said no and 33. So there was a mixed answer earlier also, now also. So actually the correct answer is no, because primary infertility means those who have never conceived. So if you look at it, this answer actually means yes, if you have conceived in the past, this means it is secondary infertility. It is not primary. Primary means you've never conceived at all. Okay, I hope this is clear now. We go over to the next question. Question number 4. Serum AMH will be very low in PCOS. Now, serum AMH is a blood test which stands for serum anti-Mullerian hormone. Will it be very low in PCOS? This is a very tricky question because when the blood test is done, the girl with the PCOS always thinks, oh, my AMH is low. Oh, does it mean I'm infertile? Ma'am had given some values. Okay. If you go back to the recording, you will know. Ma'am has given certain values. You can still think about it. So let me compare it with the answers which came earlier. Now that 40% of people are saying yes, it is going to be very low. But earlier, 14% said yes and 86% said no. So actually what happens in PCOS, serum age is not very low. Okay, it's usually the higher side. So this is where people get confused in AFC and AMH. So it will not be very low, it will be around 3 or more than 3.5 in most of the PCOS cases. So we need to evaluate other things also. It's not only serum AMH in these patients. Over to the next question, please. Question number 5. PCOS women have a high risk of pregnancy complications like miscarriages, diabetes, or high blood pressure. Please answer as yes and no. PCOS women have a higher risk of pregnancy complications. I think this is a very easy question. Last 10 seconds remaining. We will now compare this result with the initial answers. Now 83% said yes, that they have at a higher risk of pregnancy complication. When I asked this question before the session, we got an answer where 75 and 25% were having different views. 75% said yes and 25% said no. So actually the correct answer is that ideally it should be 100% yes should come, because women who have PCOS are actually having a risk of metabolic syndrome. PCOS itself is a metabolic syndrome where you have a high risk of pregnancy complications. Otherwise also, beyond pregnancy also, you are at a very high risk of developing diabetes or, high blood pressure. So, so PCOS women are at a very, very high risk of pregnancy complications. So ideally it should be 100% should come from yes. Next question, please. Sixth question is about male infertility. So azoospermia males means the men who have nil sperm count. Can they be benefited by advanced reproduction techniques which are available now, which are called as assisted reproduction techniques? So can we help these couples where there is a problem with male infertility with nil sperm count? I think ma'am also displayed this slide in the end where we were talking about male infertility. So is there a technique where we can help these men, even if they have a very nil or poor, because either they're, they have obstructive or non-obstructive reasons? So 80% so far as 86%, yes, count is going up. Okay, so 86% agree that yes, they can be helped. When I look at the previous poll answers, it showed that, okay, 100% said yes. So I think the earlier answer was correct. Yes, there is a treatment available now for these men who have a nil or poor sperm count. We can help them in, the couple can conceive by certain treatments like assisted reproduction techniques. We are going ahead for the 7th question now. Question number 7 is, recurrent termination of pregnancy can be a risk factor of infertility. Recurrent termination of pregnancy means those who have undergone a DNC can be a risk factor of infertility. Ma'am also spoke about risk factors of infertility in the first few slides, where she discussed that, repeatedly pregnancy terminations are happening. Can it cause infertility? That is a question. And so far, 100% of you have said yes, it can be a risk factor of infertility. Now we'll compare it with the result that we got before the session started. Okay, now everybody gained more knowledge now. Earlier, 14% said no, this cannot be a risk factor for infertility, but now all 100% agree, yes, repeatedly terminating a pregnancy can be a risk factor for infertility. I think that's a good improvement in your knowledge on this subject. Very good, congratulations. Now we got to the last question of today's quiz. The last question is, ovulation tracking is done using ultrasonography. So the question is about ultrasonography. Can ovulation tracking be done? So please answer as yes and no. And now 2D, 3D sonographies are available. So can this, be used to track whether the egg has been released, whether the egg has got ruptured? So that can be checked by doing a sonography. And usually it's a transvaginal sonography where the probe is inserted through the vagina of the woman. So I think 100% of you know this answer correctly, which they have said 100% of them have said yes. It can be used for tracking the ovulation. Meanwhile, let's compare it with the earlier result. Okay, very good. Everybody has understood now. Earlier, 25% said, but not too sure, so they said no. Only 75% were sure. So, correct answer is yes. It can be used for ovulation tracking. So, the answer is yes. That brings to the last question, and thank you everybody once again for again answering all the questions. So, now you know what you were in the beginning of the session and how much you know now. That's like a quick test for you. But it's also very important to, use this information for your own self. Okay. After learning so much, like in the first session, you learned the meaning of PCOS, then you learned, how and why it causes infertility. Today, ma'am told you and taught you what are the tests to be done. So, do you think you have PCOS or your daughter, your friend, or family? Let's quickly go through a set of questions wherein you will be able to, self-assess. Okay, should I go to a doctor? So, I'm going to show you a question. May I request the technical team to put about 10 questions in front of you. Now, if you answer more than 5 questions of it as yes, I think you must connect with your physician or a gynecologist and get your assessment done to confirm whether you have PCOS or no. So you need to quickly answer all the questions which are in front of you. I'll quickly read all. You just have to read as yes and no. There's no time limit, but you can quickly answer. This is your personal period history. Do you have delayed periods or do you have less than 8 periods in a year? Okay, it could be 1 day, 2 day, 3 day, but do you get every month? This means, or do you have less than 8 periods in a year? Please answer as yes or no. Question number 2. Do you have thick hair growth on your upper lip, on your chin, around the chest area, or stomach or back, which is usually a male pattern? So please answer yes or no. Third question. Have you noticed thinning of hair on your scalp? You also call it as alopecia. So please answer yes or no if you have noticed thinning of hair on your scalp. Question number 4. Do you have acne or oily skin? Simple question, yes or no. Question number 5. Has your skin on the neck, underarms, or groin area, which is the private part, becomes noticeably darker? So has your skin on the neck area, wherever there is a skin fold, or underarms or groin becomes noticeably darker? Yes or no? Question number 6. Do you have dark skin tags on your body? Do you have dark skin tags on your body? Yes or no? 7th question is, are you finding it very difficult to lose your weight? Yes or no? You can easily answer this question. Question number 8. Do you crave to eat anything sweet? Do you get sweet cravings during your periods or otherwise also? Please answer yes or no. Last 2 questions are, if you are married and if you're trying to conceive, are you finding it difficult to get pregnant? So for those who are pregnant can answer this. For those who are married can answer this question. Are you finding it difficult to get pregnant? Yes or no? And the last question is, have you had a miscarriage in the first 3 months of pregnancy? Have you had a miscarriage in the first 3 months of pregnancy? Yes or no? So out of all 10 questions, if you have, answered correctly or answered yes to more than 4 questions, there is a high risk of you being PCOS. So you can either write to us or you can visit our website, www.pcosocietyofIndia.org. You can reach out to us or you can reach out to your own doctor to share your symptoms and signs with your doctor and see if you need to evaluate and do these investigations in details for us to help you. And I think we promise to help you like this in a future sessions also. I would like Shobna ma'am to come back and just share a last few words before I give a formal vote of thanks.
I want to thank everyone, Ruby. I think it was a wonderful session. Actually, I enjoyed. I hope that all the participants also enjoyed. Thank you so very much.
So it is a joint endeavor to continue educating people at large, and I request all of you to invite more friends and other women who can, get knowledge out of this. So I heartfully thank everybody who attended the session. Without you, this wouldn't have been possible. So it is my privilege to present a formal vote of thanks to all those who were present in today's session. I primarily want to thank Dr. Durusha Madam, who is the president of the PCOS Society and whose brainchild is this program called Vijeta. And of course, Dr. Shobna ma'am for giving such a beautiful presentation. And also, she is the chair of this social awareness program committee along with me. I want to thank the entire team of Vijeta. And this is possible only because of the support that we have got from Philips India. Thank you so much, Philips, for supporting this noble cause. And I want to thank all the technical team members who have been very supportive and presenting the session. So I will close the session, but I would want to welcome all of you to our next episode, which is going to be on Thursday evening, where we will talk further. Now, since we've diagnosed, let us go a step further and see what treatment can be done. Like Shobna Madam said, the first line of treatment is diet and exercise and lifestyle management. So I'll be very happy to share some inputs on that. So I request and welcome all of you to join in that session and get more and more people to be a part of the session. Thank you so much. Stay tuned with us in this entire series of PCOS and fertility. We look forward to serve you better and give you more information. Thank you so much. Have a great evening ahead. Thank you.